Today we present our paper entitled GIS Mapping of Breast Care Access Gaps for Black Women, authored by Shelley, WhiteMeans of the University of Tennessee Health Science Center and Adelaide MURUAKO of Communicare. Black women face an unequal opportunity to survive breast cancer compared with white women. One would expect that U.S. metropolitan areas with high percentages of blacks should report similar racial disparities in breast outcomes. Yet this is not the case. Memphis and Atlanta report high disparities, while Baltimore and Oakland report low disparities. How do we account for these differences in disparities? A critical resource for reducing mortality is early detection via mammograms. To provide insights about the association between geographic location of mammography facilities and racial disparities in breast outcomes, we use GIS techniques to map the location of MQSA certified mammography centers in 10 metropolitan areas where high percentages of blacks live. Because race and income are interrelated, and both race and income may influence the geographic location of mammography facilities, we map both the race and income composition of a neighborhood and explore their association with access to certified mammography facilities. In this slide, we present the best contrast of the race-income association with the location of mammography facilities for high versus low disparity cities. We contrast here Atlanta versus Cleveland. In these maps, higher incomes represented by dark colors. Pink circles represent mammography facility locations. Closed circles represent black population. Open circles represent white population. The larger the shape, the larger the population represented. Now let's look at Atlanta, a high breast cancer mortality disparity city. Whites live in middle income and wealthy zip codes. Blacks live in poor and middle income zip codes. Poor and wealthy neighborhoods are geographically separated and racially segregated neighborhoods exist. Neighborhoods where 51% or more of residents identified as white and that had an income at least $75,000 or more contain the majority of the available mammography facilities in the area. Now let's look at Cleveland. On the right-hand side, a low breast cancer mortality disparities city. Here, we notice blacks are more likely to live in low-income neighborhoods, and substantial numbers of blacks and whites are in middle-income neighborhoods. High-income areas are predominantly white. Middle-income areas are dispersed across the city. Mammography facilities are located so that race does not influence access to care. Indeed, facilities appear across all income levels and races. A general and consistent pattern arises in low health disparity cities. Both whites and blacks are concentrated in middle income neighborhoods. Additionally, MQSA certified facilities are not clustered in affluent areas, but tend to be centrally located in the middle of the city or highly dispersed across the city, as we saw in Cleveland, regardless of income. In high disparity cities, facilities are concentrated in high and middle income white neighborhoods. Our findings are consistent with the hypothesis that segregation of neighborhoods by race and income is associated with disparities in access to mammography screenings. Thus, the intersectionality of racial residential segregation and poverty is a significant determinant of mammography facility location and breast health disparities outcomes. Thank you.